So to start, as people begin to bring their questions to us, why don't we start just with the basics? How do you define triple negative breast cancer, and has that definition changed at all over time?
Well, so for breast cancer, it's not one disease. There are many different forms and subtypes of breast cancer, and everyone's breast cancer is treated differently. So there are three things we look at under the microscope when a patient has a biopsy and is diagnosed with breast cancer. We look at the estrogen receptor, the progesterone receptor, and then a gene called HER2. So if all three of them are negative, we call it triple negative breast cancer. And what it means is that the estrogen receptor, progesterone receptors are negative. And so in very simple terms, the cancer is not being fed off estrogens. So giving an anti-estrogen treatment to a woman with triple negative breast cancer is not helpful. And then the HER2 is negative. So giving anti-HER2 treatments are also not helpful. In terms of whether the definition has changed a little bit, I would say so. Over the last couple of years, we're now using some specialized medications such as immunotherapy for patients who have advanced or metastatic triple negative breast cancer. And immunotherapy is given if we find the tumor has what we call PD-L1 staining. So for those patients with advanced or metastatic triple negative breast cancer, they're categorized as PD-L1 positive. Again, they would be getting immune therapy with chemo, or PD-L1 negative, whereas in those situations, they would be getting chemotherapy alone.
Great. Thank you so much for starting us off with to help us understand the basics. In your view, what have been some of the key treatment developments in triple negative breast cancer in the last few years? What are some of the things you're most excited about?
So I think two main things really. So immune therapy has really improved things for patients with both early and late stage triple negative breast cancer. So we're now uniformly using immune therapy plus chemo for patients with earlier stages of triple negative breast cancer. And then for those patients who have stage 4 advanced or metastatic triple negative breast cancer, who have PD-L1 positive tumors, we're also combining immune therapy with chemotherapy. And that has led to patients living longer. And the earlier stage patients are seeing more cures with immune therapy with chemo. So immune therapy really is a very big development for triple negative breast cancer. The second one is antibody drug conjugates. These are special medications that have chemotherapy tightly bound to antibodies. And, one that comes to mind is Trodelvy, which has been approved for several years now and also leads to patients with metastatic triple negative breast cancer living longer when given this medication. And then there is another medication called Enhertu, which has been approved for patients who have what we call HER2 low breast cancer. And some patients with triple negative breast cancer have HER2 low disease and also benefit from this newer medication. So immune therapies and antibody drug conjugates have really, changed things for patients.
Thanks so much for answering that. And I saw a question pop up that I'm going to ask right now as a follow-up. Someone was asking if the tumor doesn't test positive for PD-L1, does that mean you would be ineligible for getting immunotherapy?
So again, it depends on if the patient has early stage breast cancer versus metastatic or stage 4 triple negative breast cancer. So for early stage triple negative breast cancer, we are using immunotherapy irrespective of the PD-L1 status. And that has been shown to improve the outcome, the clinical outcomes for early stage patients really across the board. So we're not using that to select patients for immunotherapy. However, for patients who have advanced or metastatic triple negative breast cancer, those that have PD-L1 positive tumors seem to be the ones that benefit from immune therapy with chemo. So the approval right now for patients with advanced triple negative breast cancer is to get the immune therapy only if they are PD-L1 positive.
Thanks for addressing that, Dr. Ademuyiwa. And I'm sure there'll be more questions about immunotherapy throughout our program. So just one more question before I jump into some of these excellent questions that are coming through. We know that one of your areas of interest and research is health disparities, and was interested to hear you speak about the interaction between triple negative breast cancer and health disparities in your research.
Yes. So, as many of you may know, there is a higher rate of developing breast cancer in white women versus Black women, so higher incidence. However, the mortality is much worse for African Americans and other Black women around the world. And there are a number of reasons why, although none has really been nailed down for sure. We also see that Black women, particularly young premenopausal Black women, are more likely to be diagnosed with the aggressive form of triple negative breast cancer rather than the garden variety type of estrogen-fed breast cancer. And of course, we know that triple negative breast cancer tends to be more deadly than the hormone-fed breast cancer. So there's certainly lots of research ongoing to try to identify, first of all, why is breast cancer more deadly in Black women? Why do Black women have a higher incidence of developing more aggressive triple negative breast cancer? And what can we do about that as a research community?
Thanks for addressing that. And I'm sure I think we will get some more questions about that as well throughout our program. So I'm going to go ahead and dive into some of our questions, and I will try and get to as many as possible. So I'm going to start out with some questions that we received ahead of time from some folks who knew they were going to be here tonight. So our first question is, how close are we to finding targeted therapies for early stage triple negative breast cancer that is not BRCA positive?
Well, this continues to be an area of active investigation. There's lots and lots of clinical research going on in the US and really all over the world to try to identify smarter ways, more targeted ways of treating women with triple negative as well as other forms of breast cancer. How soon are we in terms of treating everybody in a very individualized fashion, depending on what proteins or mutations or biomarkers their triple negative breast cancer has? I think it's still, probably a ways away. But again, there's lots and lots of ongoing clinical research in this arena.
Thank you. And sort of on a similar vein, someone is asking, is TNBC heterogeneous? And if you can explain what that means, that would be helpful. And should tumor biomarker testing happen upon diagnosis? And I can't tell if this person has early stage or metastatic breast cancer. So if you could address those situations as well.
Yes, absolutely. Triple negative breast cancer is extremely heterogeneous. I mean, in the clinic, we would see two patients that have identical breast cancers, so both triple negative, same race, same age, same grade of disease, same tumor size, nodal involvement, and one patient will have an excellent response to chemotherapy and will be cured of her disease, while the other patient will have a not so good outcome, and we really don't have a good understanding of that. So absolutely, triple negative breast cancer is very, very heterogeneous in the clinic. And even the biology itself is quite heterogeneous. So there's been research trying to subdivide triple negative breast cancer into many different entities. And, what we see in the research arena is that these different entities sort of behave differently in the clinic. Although we're not quite there yet in terms of treating each entity separately. We kind of lump them all together and treat them all with chemo and immunotherapy. But if you look molecularly at triple negative breast cancer, there's certainly some differences, and they do behave differently. So, hopefully in the future, in the not so distant future, hopefully we will be subdividing triple negative breast cancer even further into the molecular subtypes, and hopefully we'll be a little bit smarter about how to treat patients with the individual and distinct molecular subtypes.
Thank you. So maybe at some point when we do this webinar, we'll have to give it a different name. It won't be called triple negative breast cancer anymore. So in some ways, you talked a little bit about this with the last question. One of our attendees is asking, what are the key factors in determining a person's prognosis with triple negative breast cancer?
So I'm assuming that person is talking about early stage breast cancer. So typically for more than 90% of women with triple negative breast cancer, they get some sort of systemic chemotherapy. So chemotherapy with or without immune therapy, depending on, the extent of disease. And majority of the time, we prefer to do this first before surgery. So usually we would deliver the systemic therapy, and then after the regimen, the woman will go and have surgery. And after surgery, the specimen will be sent to the pathologist to look at it under the microscope to determine if there's any cancer left over. So if there's a pathological complete response, meaning that the chemotherapy killed the tumor 100%, the outlook for that patient is excellent. The prognosis is very, very good. There's a very, very small chance of ever having a relapse. But if the chemotherapy didn't work at 100% and was not able to eradicate all the cancer, and there was some degree of cancer left over, the prognosis is not as good. And of course, that depends on the amount of cancer that was left over. So if it was just a little bit in the breast, the prognosis is much better than if it was a huge lump left over with nodal involvement.
Thank you. Thanks for answering that question. So we have a couple of questions from folks who, for one reason or another, were not able to get chemotherapy as part of their early stage triple negative breast cancer treatment, and are wondering how that could influence their long-term outcome because they weren't able to get chemotherapy.
So certainly if patients normally should have received chemotherapy. So if the tumor is a certain size or has gone to the lymph node, studies show that giving chemotherapy leads to more cures than patients who don't get chemotherapy. So the risk of recurrence in, a clinical stage, a certain clinical stage of a patient who did not get chemotherapy would be higher than patients who are able to, get the recommended chemotherapy. But that is not to say that, all patients who don't get chemotherapy will certainly suffer a recurrence. No, the risk of recurrence is just higher, but certainly not 100% guaranteed to have a recurrence.
And so now that there are some other treatments available other than chemotherapy for someone who might not be able to get chemotherapy, so these people all had surgery and radiation, but would there be other full body treatments or systemic treatments that might be available to them?
So in the earlier stage setting, the only other treatment that we use for triple negative breast cancer other than chemo would be immune therapy. And generally, immune therapy is not all that effective when not combined with chemotherapy. So, most clinicians will not be recommending immune therapy by itself.
Thank you. Thanks for addressing that. So I have a question from an attendee about treatment schedules. So this person was diagnosed with triple negative breast cancer and is taking Taxol chemotherapy once a week for the past 3 months, and then has had a pathological complete response, and was told they would need to continue getting chemo once a week for the next 3 months, and wanted to know what impact there would be about trying to do it less frequently than once a week. Is that a standard? Is that
so there are really a variety of treatment options, of chemotherapy regimens. There are a variety of schedules. Sometimes we give chemotherapy weekly, sometimes we give it every other week, called dose dense. Sometimes we give it every 3 weeks. It just depends on the regimen that the treating physician thinks is most appropriate for the patient. But there's certainly, a lot of different options for patients.
Thank you. Thanks for addressing that. Our next question is from someone asking, what ER percentage is considered to be estrogen receptor negative?
That's a really good question. I'm not sure there's a real uniform consensus around the world. Some studies suggest that, any ER staining, so even 1%, could be considered as estrogen receptor positive. However, in the clinic, we know that those with low ER staining, so usually less than 5 or 10%, tend to behave more like triple negative breast cancer patients. So for instance, if I see a patient with an ER of 5%, I would typically treat that patient as triple negative breast cancer and offer them chemotherapy with immunotherapy in the early stage setting.
So Dr. Ademuyiwa, if someone has sort of a lower percentage estrogen receptor cancer, what kind of questions should they be asking their doctor if they're wondering whether they should be treated differently because of that?
Well, so, two questions. So first of all, would they be getting a regimen? Would they be approved for a regimen that is more suited for a patient with triple negative breast cancer? And then at the end of their surgery and radiation, would they be getting anti-estrogen treatment as well? Because even though, for some patients, the estrogen receptors are on the lower side, we still give them the benefit of the doubt and offer them anti-estrogen treatments, kind of depending on the clinical scenario. So if it's really, really low in the single digits and they have an excellent response to chemotherapy, and they have complete eradication of the tumors with a pathological complete response, we might still offer it. But if they have, any side effects, we might have a low threshold to discontinue anti-estrogen treatment. So it really depends. But generally, if there's, any estrogen receptor positivity, we tend to still offer anti-estrogen treatments.
Thanks for addressing that. So there's a couple of questions about the period after active treatment. The first one is, when do you see peak numbers of recurrences in triple negative breast cancer? Does it start from the diagnosis date or the date from surgery?
Again, that's somewhat controversial. People define it differently. I tend to define that as the time from diagnosis. And generally for triple negative breast cancer, majority of the recurrences happen within the first 5 years. And again, most of them would be within the first 2 years. Having a recurrence after 5 years with triple negative breast cancer can still happen, but is rare. It's not that common.
Thank you. So I'm going to pivot in a couple of minutes to some questions from our metastatic participants, our individuals with stage 4. But just as a follow-up to that question, we had a question ahead of time from someone with metastatic triple negative breast cancer who was successfully treated 17 years ago and has remained with no evidence of disease. And also knows another person who was treated 20 years ago and went 20 years with no evidence of disease and recently had a progression of her cancer. And so she's asking whether you are seeing any increase in the number of later recurrences of triple negative breast cancer.
Not that we have noticed clinically. Again, these are very unique circumstances. And, what we believe in such patients is that it actually might be a completely second primary, so a second cancer rather than a recurrence of the first one. Sometimes we're not able to really conclusively determine if this is a recurrence or a second primary. Sometimes we can look at both specimens under the microscope and try to see if they look identical or if they have the same receptors, look at the ER, PR, and HER2. But generally, if there is a very long time between a recurrence or progression, it can actually be a second primary. That is possible.
Thank you for that. So I'm going to move on to another question from someone with early stage breast cancer. Once you're done with treatment, what are steps for future prevention, especially if you have a BRCA1 mutation?
So a number of things that patients with BRCA1 or 2 mutations can do to decrease the risk of having a second primary or other cancers such as ovarian cancer. So sometimes they can be offered bilateral mastectomies and to take off both breasts because, if they have one breast cancer and that has been successfully treated with that mutation, there is a high risk of developing another breast cancer. So higher risk than the general population or the population without these mutations. So bilateral mastectomies can be offered. Removing the ovaries can also be offered. That also has been shown to decrease breast cancer from developing. And if patients don't want to undergo surgery or they don't want to lose both breasts, then they can be screened with both mammograms as well as MRIs rather than just the usual yearly mammograms. And the way we do that is we do one of those tests at the same time once a year or alternating every 6 months. So that is generally the follow-up for patients at high risk, patients with BRCA1 or 2 mutations. And then, of course, there's now newer medications called PARP inhibitors. And these medications are exclusively for patients who have BRCA1 or 2 mutations. And so if a patient who has developed breast cancer with this mutation qualifies and the tumor has to have certain characteristics to qualify, we are actually now recommending one of the PARP inhibitors, Lynparza, to be given for 1 year to reduce the risk of the cancer coming back.
Thank you for explaining that. Someone is asking a question to better understand what immunotherapy is and is asking whether it's a form of chemotherapy. And I'm wondering if you can address that question.
Well, the way that I like to explain it to my patients is that in very simple terms, so it's not chemotherapy, first of all, it's sort of special medication that takes the brakes off the immune system, or sort of revs up the immune system to fight cancer. So we all have several different cells in our bodies that can fight infection, cancer, and basically foreign things that should not be in the body. And these are T cells. So immunotherapy, again, there are many, many different forms of immunotherapy. In very simple terms, it revs up immune cells. T cells, are a component of immune cells to be very activated and fight unwanted passengers in the body like cancer. So that's what immune therapy does in very simple terms. Now, because sometimes the immune system can be so revved up, it can fight cancer, it can also fight good parts of the body. And that's why we see sometimes side effects of immune therapy, such as inflammation of body organs, body parts such as the thyroid. The immune system can fight the thyroid gland, and patients can need thyroid pills. It can fight the colon, and patients can have diarrhea. It can fight the skin, and patients can have rashes, and so on and so forth. But basically, it revs up the immune system to fight cancer.
Thank you. Sorry, I knew what I wanted to ask you and I lost my question. So I have a question about Trodelvy from someone with metastatic breast cancer. I've read of some people getting Trodelvy on a schedule of 1 week on and 1 week off to lessen side effects, which is different than I believe the FDA approved schedule of having it on days 1 and 8 of a 21-day cycle. Do you know if there is data supporting other schedules for administration?
So these are judgment calls that we make clinically. And, we sometimes adjust the doses and schedule of treatments to accommodate and allow for a good quality of life and allow patients to stay on treatment so that they can benefit from treatments. The way the studies were designed and the way the FDA has approved Trodelvy is to get it 2 weeks on, 1 week off. But sometimes you find that could be hard on patients. Again, not all patients. And sometimes we have to lower the approved doses and sometimes even change the approved schedule just so that patients can get the medication. Again, we usually would be starting at the approved dose and schedule, but based on the tolerability, we make adjustments in clinic.
Thank you. Are there any improvements for African American women with triple negative breast cancer?
Yes, so all these newer medications that I have mentioned, so Trodelvy, Enhertu, sacituzumab, other immunotherapies and chemos are also active in Black women with breast cancer. Women from all races benefit. And, many of the studies have looked at the benefit across different races. And we find also that the improvements are not limited to just one race, but all people seem to benefit from these medications. I mean, of course, we know that, African Americans are underrepresented in clinical trials, but those that do participate in clinical trials seem to benefit from the medications, as well as in clinic. We do see benefits for Black women as well.
Are there clinical trials that are specifically looking at Black women and triple negative breast cancer?
Not that I know about specifically.
Thank you. Another attendee is asking, other than Keytruda, are there other immunotherapies that are used for triple negative breast cancer?
No, so Keytruda is the only one that is currently available and approved for triple negative breast cancer. There are many, many other immune therapies which are in clinical trials to see if they would also benefit patients with triple negative breast cancer. But right now, Keytruda is the only one we have available that is approved.
Thank you for answering that. Another person is asking whether there are co-occurring illnesses that impact outcomes for people with metastatic triple-negative breast cancer.
Well, that question is maybe a little bit difficult to answer. Well, I will say, so if a patient, for instance, if a patient has a lot of comorbidities, a lot of other medical problems, like hypertension, diabetes, cholesterol, things like that, or lung disease, heart disease, and they're too sick, or then have more toxicities than other patients who don't have as many medical problems, then obviously that will impact the clinical outcomes for that patient, because they will not be able to get, the same doses and schedule and some treatments. So in a sense, if a patient, or if you women or men have more other intervening medical problems, then that certainly could impact how we're able to deliver treatment and subsequently could impact the clinical outcomes.
And thank you. And there's another question about the relationship between outcomes and having a BRCA mutation or another hereditary gene mutation. What do we know? In general, there are a lot of questions about outcomes and about survival rates in metastatic triple-negative breast cancer. And that's a hard question to answer and a hard question to ask. So if you could speak to that, I would appreciate it.
Yeah, it is. Again, it's quite heterogeneous. Some patients do well and others don't. Again, it kind of depends on the tumor biology, how well they respond to initial treatment. But, what I will say is that for patients who have triple-negative breast cancer, so early stage triple-negative breast cancer, who have BRCA1 or 2 mutations, they seem to do better. A subset of them seem to do better than patients who do not have these mutations. Why? Because those patients who have BRCA1 or 2 mutations are very sensitive and respond quite well, for the most part, to chemotherapy. So a patient with a BRCA1 mutation is probably more likely to have complete tumor eradication with chemotherapy and subsequently do much better than a patient who does not have a BRCA1 or 2 mutation. Again, I am not saying that those patients who don't have BRCA1 or 2 mutations don't do well. They also do well, but the BRCA1 or 2 patients tend to be quite sensitive to chemotherapy.
Thank you. And also, I think, how much do we know about outcomes in triple-negative breast cancer and in metastatic disease in general? How much information do we have about how long people live with metastatic triple-negative breast cancer?
Well, we have information from the recent clinical trials. So recent clinical trials that kind of divided people into 2 groups. So one group of patients got immunotherapy with chemo and the other group got chemotherapy alone. And we know that for those patients who got immunotherapy with chemotherapy, they live longer than those patients who got chemotherapy alone. Again, this is for patients who are PD-L1 positive who would usually qualify for immune therapy. So we do have those numbers. And again, there are many new medications, again, also including Trodelvy and Enhertu. And these medications are leading to patients living longer. And so those numbers are available. And, when I started independent clinical practice more than a decade ago, I have seen the change myself in clinic. I see it every day. Patients with metastatic triple-negative breast cancer are now living longer than they were 10 years ago before we had these new medications. Of course, we still have a long way to go in terms of, moving the needle forward and hopefully curing more patients. But we're certainly seeing that with newer medications, better supportive care, patients are living longer and are tolerating treatments better.
Thank you for addressing that, Dr. Ademuyiwa. Can you please talk about capecitabine treatment or Xeloda treatment, the benefits and effectiveness?
So in the pre-immunotherapy era, again, this is for patients with early stage disease, there was a clinical trial called the CREATE-X study, where, again, this was completely before we were using immunotherapy many years ago. Patients who got initial chemotherapy before surgery, we looked at their tumors after they had surgery. And for those patients who had cancer left over, so those that the chemotherapy did not eradicate the cancer 100%, giving them capecitabine or Xeloda led to them living longer, led to more cures. So that became the standard of care. For patients who got chemo and didn't get a pathological complete response, we offered and recommended Xeloda after. However, now we have immune therapy, which we're combining with chemo upfront before surgery. And the question is there still a role for Xeloda for those patients who get immune therapy plus chemo and still don't have complete eradication of the tumor? We don't have those answers because those studies have not been done. However, many of us, including myself, are still offering a Xeloda just so that we can improve the outcomes as much as we can for those women. Again, because we know that not achieving complete eradication of cancer, not getting to that pathological complete response makes the risk of recurrence a little bit higher than if patients achieved a pathological complete response. So we do everything we can to help those women.
Thank you. We have a couple of questions about places where in the body triple negative breast cancer tends to spread when it metastasizes. Is it common for TNBC to spread to the brain?
Yes, it is. So there are 3 clinical subtypes of breast cancer. There's the triple negative one, which is the subject of today's discussion. That has a predilection to go to the brain. There's the HER2 positive breast cancer, also has a tendency to go to the brain, and the hormone receptor positive breast cancer, less likely to go to the brain. So the more aggressive subtypes do have a tendency to go to the brain. And the other part of your question, where else does it go? Can it go? It's unpredictable, but generally it can go anywhere in the body. So lungs, liver, bones, brain, lymph nodes, even subcutaneous tissue, rashes, lumps and bumps under the skin, and so on and so forth. But generally, lungs, liver, bones, and brain.
Thank you. Yes, someone had asked specifically about spread to the abdomen or the peritoneal cavity, and she wondered whether that was a common site of metastasis for triple negative.
That can happen. We do see that in clinic. It can happen.
Thank you. So I'm going to turn to our next question from an attendee who participated in a clinical trial with Keytruda and had stage 3 disease, and is looking for advice about what she can do to prevent recurrence. She is now 4 years from her surgery, and is looking for advice about, in addition to mammograms, what else can she be doing?
So mammograms, attending the recommended follow-up examinations with a doctor, keeping an eye on having a good body mass index. Exercise is very good for cardiovascular health, and the jury is still out on preventing recurrences. Some studies are positive, some studies are negative, but I always, take it as a teachable moment for my patients to, live a good lifestyle with eating healthy, reducing carbohydrate intake, as well as fats and focusing more on vegetables and proteins and incorporating daily exercise into their lifestyle.
Thank you. So someone asked a great question, and also I meant to thank the last person for participating in a clinical trial and for sharing your story here. Someone is asking if we can define early stage breast cancer versus later stage breast cancer. Can you please speak to that? That's
Yes.
a great question.
Yes.
Thank you.
Yeah, that's a very good question. And sometimes the lines are a little bit blurred, but generally the way I approach it and the way I explain it to my patients in clinic is that two buckets. One is patients who have metastatic breast cancer, and in those situations, metastatic or locally advanced and unresectable, so unremovable. So metastatic breast cancer will generally be those that have spread outside the breast and armpit area and have spread to a different organ. Again, commonly the lungs, the liver, bones, or the brain. Those ones typically are not curable. So the treatment for those ones is to keep things under control and achieve the best quality of life and the longest time we can with treatment. And then if patients don't have metastatic disease, everybody else kind of falls into the bucket of potentially curable. And for those patients, we involve a multimodality management plan with chemotherapy, possibly with immune therapy if they qualify, surgery, and radiation if necessary.
Thank you. There was another question about DCIS and triple negative breast cancer, and what do we know about how it should be treated?
So we do not, so triple negative breast cancer by definition is invasive breast cancer, not DCIS. So DCIS is never classified as triple negative breast cancer. The reason being that the third marker that I mentioned initially, the HER2 status, is not checked on DCIS. So we do not really know if DCIS is triple negative or not triple negative. And the reason we don't check HER2 status on DCIS is because it's a non-invasive cancer, so it's never treated with chemotherapy and anti-HER2 treatments. So those terms are completely separate.
Thank you for addressing that. A couple of folks are asking questions about the relationship between triple negative breast cancer and pregnancy. Can you speak to how common it is to be diagnosed with triple negative breast cancer after pregnancy and pregnancy-associated breast cancer?
So pregnancy-associated breast cancer in itself is not that common. However, of course, we do see pregnancy-associated breast cancer. And in terms of triple negative versus HER2 positive or estrogen fed, they can all happen in patients who are pregnant. I don't think having a pregnancy-associated breast cancer is more likely to be triple negative or HER2 positive or hormone receptor positive. They all occur in pregnancy-associated breast cancer, which in itself is not that common.
Thank you. We also have, so we have several questions asking specifically about the KEYNOTE clinical trial and when there will be reporting for longer, for more years of follow-up. For I think we have 5 years of follow-up, and they're asking about 10 years, 7 years, and longer periods. Do you know whether those will be reported?
If they are talking about the KEYNOTE 522 study, which is the study in early stage patients, I have only seen the 3-year event-free survival follow-up. I don't think the 5-year follow-up has been reported yet. So I assume that probably would take another couple of years to be reported. The 3-year follow-up, I believe, was reported just last year.
Thank you. So my next question is from someone with metastatic breast cancer or stage 4 breast cancer, asking about what the most promising new treatments are in that setting.
Did you say, sorry, can you repeat the question?
Sure. She's asking what you're seeing as the most interesting research, most promising researches in stage 4 breast cancer for triple negative disease.
I would have to say it's the antibody drug conjugates. There are quite a number of them in clinical development, and they all look extremely promising. So we're probably going to be hearing more and more about them in the near future. And we're all anticipating that more of them are going to be approved coming around pretty soon. They are showing quite good results in clinical trials. The antibody drug conjugates, I think, are the exciting new molecules in triple negative cancer.
Great, thank you. I'm seeing a couple of questions from people who finished their treatment for early stage breast cancer before immunotherapy was approved in that setting, and are wondering, is there any benefit to them a year later, 2 years later, to get immunotherapy?
Well, that's a really good question. And the simple answer right now is we don't know. So there is a clinical trial, there are clinical trials that are ongoing to figure out if patients didn't get initial chemotherapy with immune therapy with surgery, before surgery, do they have a benefit of getting the immune therapy after surgery? And we don't have results of those clinical trials right now, so we don't know if there's a benefit of that strategy. However, many scientific papers and studies seem to point to a good benefit because there's synergy. It works better with chemotherapy given before, and then of course continuing it after surgery is done. Now, giving it as a single agent without chemotherapy, those studies are not available yet, so we don't know. And again, those studies are looking at patients who just finished surgery, not patients who have finished all treatments for, a year or two. We just don't have those studies even being done, so we don't know.
Okay, thank you. So some really important research questions as well. Our next question is from someone asking, if you have a mastectomy for early stage triple negative breast cancer, do you still have to have chemo and radiation?
So yes, those are two completely separate, separate questions. So having a mastectomy does not mean that you don't need chemotherapy. The chemotherapy decision is made completely independent of whatever surgery a patient is recommended to have. Same thing with radiation. There's some specific criteria for receiving radiation. So in general, if a woman has a lumpectomy, or otherwise known as a partial mastectomy, and is able to preserve the breast, that usually goes hand in hand with radiation. And then for women who have mastectomies and remove the whole breast, some of them still need radiation, particularly those that have big tumors, or if the cancer had gone to the lymph nodes, those patients are generally recommended to have radiation as well. But the chemotherapy question, like I said, is completely independent of the local therapy with surgery and radiation.
Thank you for addressing radiation, because there's a number of questions from folks asking whether radiation is specifically indicated for triple negative breast cancer, which it sounds like it is. It has less to do with it being triple negative breast cancer than the extent.
Yes, it has less to do with it being triple negative. Generally, the indications are the same across the board for even those patients who are hormone receptor positive, HER2 positive. Generally, they're the same indications for radiation. There are some few nuances that the radiation oncologists look at, and sometimes that goes into their decision making. But overall, in broad generalities, the indications are quite similar.
Thank you for addressing that. Our next question is about when to get chemotherapy. Is it critical to have chemotherapy before surgery? This person had adjuvant chemotherapy, so had the chemotherapy after surgery.
It is highly preferred to have chemotherapy before surgery if you have triple negative breast cancer and the size is a certain size, so generally greater than 1.5 centimeters or so, or if the lymph nodes are positive. The reason being that gives us an idea of, number one, the prognosis. So for instance, you get the chemotherapy with or without immune therapy first, go ahead and have surgery. And if all the cancer is dead, we can tell the woman that the prognosis is excellent. If there's cancer left over, then we generally recommend more treatment after. So with clinical trials or Capecitabine, Xeloda. But if you have surgery first, then that information on if the chemotherapy would have killed all the cancer is not available. So it cannot really guide prognosis and cannot really guide what we do after surgery. But of course, it is not in every case that we do chemotherapy before. So in patients who have very small cancers that are triple negative and their nodes are negative, most of the time we will have them do surgery first, and we will see, exactly what kind of chemotherapy regimen, if any, we will give after surgery. So it kind of depends on how big the tumor is and if there are nodes involved. And if those, if the tumor is a certain size and nodes are involved, we prefer to do it before.
Thank you for addressing that, Dr. Ademuyiwa. Our next question is from a woman who was diagnosed with triple negative breast cancer at age 78, and is wondering if there are differences in treatment, success rates, or other outcomes for older women who are diagnosed with TNBC.
We look at the overall, the physiology of the patient, how fit the patient is, not really so much as, how old the patient is. There are some patients who are in their 70s who are extremely healthy and function or have the physiology of much younger women, whereas there are some patients who are in their 50s and are much, much sicker, have a lot of medical problems and cannot tolerate chemotherapy. So we have some scores that we look at, some calculations that we can do to determine how well an older woman will do with chemotherapy. And as long as they're fit, and as long as we deem that they have a certain number of years left to live, we administer the appropriate chemotherapy to that woman. They do just as well as younger women in terms of, outcomes if they receive appropriate standard of care.
Great,
so we don't use age to withhold treatment. We use more of, physiology, medical problems, how fit they are, and things like that.
Thank you for clarifying that. Our next question is about antibody drug conjugates. If you experience a progression after taking one, can you go back to getting chemotherapy on its own and then return to an antibody drug conjugate?
Well, this is the $1 million question, how to sequence therapies, because we are, like I said, we're probably going to be having we already have 2 antibody drug conjugates available. We have Trodelvy and Enhertu, and how to sequence both of them is an area of intense investigation. Nobody knows the answer to that currently, but in the clinic, if you progress on 1 antibody drug conjugate, we are still recommending chemotherapy for patients who remain fit and still want to have their cancers treated. We do that, every day. But again, the question of how to sequence all the antibody drug conjugates we're probably going to have in a few years remains to be seen.
Thank you. So
there are some studies showing that you can benefit from one, even if you've gotten a different one before. But this is an area that is still being actively investigated.
Great, thank you. Our next question is from someone who was diagnosed with 2 separate breast cancers in either breast at the same time. One was triple negative and one was another subtype, HER2. Is there any research on treatments and outcomes with people in such situations?
Well, so it kind of depends on the outcome. We look at really the outcome of, perhaps the more aggressive cancer. So if they have a triple negative in one breast and then an estrogen fed in another breast, the outcome for that woman would probably be driven by the more aggressive triple negative breast cancer and how she did with treatments and so on and so forth. But specifically to the question as to, is there data looking at the outcome of women with 2 separate primaries? I don't think we don't have that information, because even though it happens, it's not that common.
Thank you. Our next question is, why do some people get Taxol and carboplatin first and others get AC treatment first? So I think that sort of the larger question is, how is the chemotherapy treatment chosen for triple negative breast cancer?
So the KEYNOTE 522 regimen looked at patients with triple negative breast cancer and divided patients to chemotherapy or chemotherapy with immune therapy. And the regimen they chose the chemotherapy regimen was 4 chemos, the AC plus Taxol carbo. They gave the Taxol carbo first. But traditionally, we have given AC first before we started using immunotherapy. So the bottom line is it kind of depends on the clinician. I'm not sure that there is one sequence that is better than the other. So commonly, I will do according to the KEYNOTE 522 regimen, but I really don't think there's any downside with doing the AC first and doing the Taxol carbo after, as long as you get the full regimen.
Thank you for explaining that. Another participant is asking whether there are clinical trials with vaccines available for triple negative breast cancer.
Yes, there are clinical trials going on with vaccines in triple negative for early stage patients, as well as patients with metastatic disease. And, there's several active that are going around all over the country.
Our next question is from someone who says they had a poor initial response to chemotherapy with a stage 3 diagnosis and is curious about the use of circulating tumor DNA tests to monitor for recurrence and whether that's used in triple negative breast cancer.
Yeah, this is certainly an emerging field. And we are starting to consider, there are many trials looking at the clinical utility of using circulating tumor DNA and circulating tumor cells to predict who will have a recurrence, who has what we call minimal residual disease that we cannot really see on a scan or any other way. And many of those studies, including studies done here at Washington University, show that yes, indeed, we can use circulating tumor DNA to predict who will have a worse outcome. So if you have positive circulating tumor DNA after your treatment, or it rises, then there's certainly data suggesting that that patient is at higher risk of developing overt metastases. So we know that we can predict this. The main question now is that what can we do about it? So finding bad news early, how can we intervene? Unfortunately, there have been studies showing that trying to intervene early in those patients who you have residual disease, or you can detect things by circulating, they haven't really shown much clinical promise. There are still studies that are ongoing, but this is the reason why, some clinicians might be reluctant to check circulating DNA in this circumstance, because if you find it, what do you do about it? Particularly if you now check scans and you don't find any evidence of overt metastases. That's very anxiety provoking. And so far, we don't really have any tools to interrupt, what we think will happen to such a woman. So it's an emerging field, certainly lots and lots of active investigations still ongoing. But I think in the future, we may have some idea of what to do in such circumstances. Right now, we don't really know.
Thank you for addressing that. I know we get a lot of questions about these tests and when they're used and how they're used, and are hoping we can provide some answers to our community soon. So really appreciate that answer. We have a couple of questions from attendees who are asking whether there is a connection between the COVID-19 vaccine and triple negative breast cancer, or diagnosis of triple negative breast cancer. Could you please speak to that?
I have not seen, any data suggesting that the vaccine, receipt of the vaccine or lack thereof, will make a woman more, prone to develop triple negative breast cancer. What we know is that, getting the vaccine can lead to swollen lymph nodes. This is just more or less a way the vaccine works. But these lymph nodes that happen with the vaccine are not malignant. They're not breast cancer. They go down with time. And we haven't seen any increase in triple negative or any other forms of breast cancer from the vaccine to date.
Thank you for addressing that. So I have a couple more minutes for questions, and then unfortunately we'll have to wrap up. But we do have one question from a person living with metastatic breast cancer who is on chemotherapy and immunotherapy. How long can I continue to take immunotherapy? What do we know about that?
Well, what we know is that we don't really know if there is, how long patients can be on immune therapy. We continue immune therapy and chemos as long as they're working and as long as they're being tolerated, as long as they're not causing big problems with side effects or worsening quality of life, and they're keeping, cancers under control. We continue them. Is there, we haven't seen that there's a certain maximum that a woman of immune therapy that a woman or a man can receive.
Thank you. So for our last question, we have someone who's asking, what can patients do in addition to listening to their physicians to ask the best questions to ensure that they are getting the best care for triple negative breast cancer?
Well, asking the best questions, that sometimes might be challenging, honestly, because, most patients are not in the medical field and they don't necessarily know exactly what questions to ask. But, just listening to your doctor, if something doesn't feel quite right or you're not understanding, which happens quite a bit, asking for more explanation. Don't be shy or embarrassed about questioning your doctor. We're there to help. And if you feel that you're still not getting the answers or understanding, or you feel that the relationship is not good, feel very, very free to always seek a second opinion so that you have a good understanding of, your situation and how you can help yourself. So think about a second opinion if you don't feel comfortable with the doctor who is treating you. And be an advocate for yourself. Bring family members and friends to the appointments. So, things that you miss or you don't understand, you have a second set of ears, somebody writing down information for you.